Hello, my name is Paris Mandy. I will complete a presentation about hypertension. The purpose of this presentation is to discuss a case study and break down the pathophysiology of the disease process. So let's get started. This is the case study of EW. EW is a 40-year-old African-American male who is having difficulty managing his hypertension. Today, he arrived to his primary care physician's office for a prescription renewal and a physical exam. EW was diagnosed with hypertension 11 years ago. He also gets chronic sinus infections. Other medical history include pneumonia 6 years ago and one episode of major depressive disorder which occurred when his wife killed herself 5 years ago. He's had no past surgeries. EW's family history. EW's father died at 49 from acute myocardial infarction and hypertension. His mother has diabetes as well as hypertension. His brother died at 20 years old from complications of cystic fibrosis. He has two sisters who are both alive and well. EW lives alone, but he has a 15-year-old son who lives with his maternal aunt. Unfortunately for EW, he has not seen his son or talked to his son in 4 years. EW is an air traffic controller who stopped smoking about 1 year ago. He admits to drinking several beers every day to relax, and he does not pay attention to his diet. He salts his food prior to tasting it, and he does not engage in regular exercise. The medications that EW take: hydrochlorothiazide, 50 milligrams PO QD, Sudafed, 60 milligrams PO Q6 hours, and he also takes Qvar, one spray into each nostril every 6 hours as needed. His allergies to medications is penicillin, in which he gets a rash. Let's discuss his physical exam. During his physical exam, EW states that his overall health is pretty good, besides being obese and gaining 20 pounds over the last year. During his physical assessment, he states that he gets short of breath with activity such as climbing stairs, which is getting worse. He's had some chronic pain from his knee from a previous injury in which he treats with extra strength Tylenol. His vitals are 155/96, heart rate of 73, respirations 15, temperature 98.8. His height is 5'8", with a weight of 221 pounds, making his BMI 31.0. Let's continue with the physical exam. What was noticed to be abnormal was his lungs, in which the provider noticed mild bilateral basilar crackles. The provider also heard a prominent S3 sound and noticed limited range of motion in his right knee. An abnormal lab was GGT, which can be indicative of drinking too much alcohol. So what is his diagnosis? He is diagnosed with primary hypertension. Primary hypertension is defined as consistent elevation of arterial blood pressure. Most common primary diagnosis in the US. Unfortunately, African Americans have the highest rate of 44% for hypertension. And many who are diagnosed with hypertension have difficulties controlling their blood pressure. 95% cases of hypertension do not have a specific cause. So let's discuss maybe some possible causes of hypertension. EW might have due to a variant APOL gene could be associated with hypertension and renal disease. This gene is found in African Americans. It can also be from inherent defects of renal sodium excretion, insulin and insulin sufficiency. The risk factors for hypertension include family history of hypertension, in which EW's mom and dad both had hypertension, advancing age, EW is in his 40s, gender, men younger than 55 and women over 70, EW is a man about 40 years old, being African American, having a high dietary sodium intake, glucose intolerance or diabetes, cigarette smoking, in which EW stopped smoking 1 year ago, obesity, in which EW has a BMI of 31.0, and heavy alcohol use. EW states that he drinks several beers every day to relax. Another last risk factor is low dietary consumption of the electrolytes such as potassium, calcium, and magnesium. So let's talk about the pathophysiology of hypertension. Hypertension is caused by either increased cardiac output or peripheral resistance. Vascular resistance, or the increased blood viscosity, causes a pressure change in which it is difficult for people to excrete salt back into their urine. This shift in pressure is known as the pressure natriuresis relationship. The sympathetic nervous system is responsible for the maintenance of blood pressure by promoting cardiac contractility and inducing arterial vasoconstriction. Unfortunately, for individuals with hypertension, they put more stress on the SNS, causing it to engage in overactivity. So let's talk about the renin-angiotensin-aldosterone system. This plays a significant role in hypertension. The RAS system is a homeostatic mechanism. The release of renin synthesizes of angiotensin II. Angiotensin II causes vasoconstriction, renal and salt retention, which stimulates tissue growth and inflammation. And this is how it presents in a normal individual. Unfortunately, angiotensin in abnormal amounts cause too much retention of sodium, insulin resistance, increased endothelial dysfunction, increased vessel growth, increased platelet aggregation, thrombosis, and smooth muscle, leading to cardiovascular complications and kidney disease. The important thing to remember about the abnormals of angiotensins is how hypertension can lead to stroke. Stroke can occur when the blood pressure is too high, as well as when a blood clot is sent and blocks off the circulation in a patient, which results in cell death in the brain. So if you think about it, hypertension can cause blood clots as well as can cause stroke. RAS abnormalities. Aldosterone causes sodium retention in the kidneys and cardiovascular complications. ACE inhibitors, known as angiotensin converting enzyme inhibitors, oppose the activity of angiotensins and effective reducing the blood pressure and hopefully protecting the kidneys. It's important to note that with this medication, there is an adverse reaction of angioedema. Angioedema happens more often in African Americans, so this medication may not be appropriate for EW. Let's discuss other contributors to hypertension. Obesity. Fat cells release leptin and adiponectin. Leptin communicates with the hypothalamus to control body weight through appetite inhibition and increased metabolism. Unfortunately, too much leptin in the body can build resistance, and the body is unable to control its own body weight. The reduction in these functions can cause the CNS to react, decreasing the body's ability to excrete sodium, which again leads to increase of aldosterone and leads to high blood pressure. Adiponectin is a protein produced by adipose tissue, but it is reduced in obese patients. Less of this protein leads to insulin resistance, decreased endothelium-derived nitric oxide vasodilators. So this working with the SNS and the RAS results in vasoconstriction and retention of sodium in water, which again leads to hypertension. Let's talk about some of the medications used to treat hypertension. You have ACE inhibitors. The ACE inhibitors block the action of renin, target hypertension through the RAS system. But again, that common side effect of angioedema should be considered when prescribing this medication to African American patients. These medications are going to be your pril medications, such as lisinopril. Next, we have beta blockers. Beta blockers work on the SNS by reducing the blood pressure from relaxing the blood vessels. They can decrease the rate of the force of the contraction of the heart muscle. This will lower the heart rate. So it is important for when a patient presents to the emergency department with bradycardia that the nurse and the provider does a medication history and find out if the patient is taking beta blockers. Often when a patient presents with bradycardia and does not show any other EKG abnormalities, it might be that they took too much medication, too many beta blockers. The beta blockers are the old medication, such as labetalol and metoprolol. Medications continued. Diuretics. We already discussed that EW is on a diuretic called hydrochlorothiazide. Diuretics are one of the first-line drugs for treating hypertension. These drugs can also help the kidneys excrete some of the extra sodium and decrease fluid when it builds up in the heart due to congestive heart failure. Diuretics work very well with other medications such as calcium channel blockers or ACE inhibitors. Calcium channel blockers have a direct effect on the blood vessels. They cause relaxation of the blood vessels and work very well with diuretics. Examples of calcium channel blockers are nicardipine and nifedipine. Okay, let's bring it all back to EW. He has the risk factors of being obese. He gained 20 pounds in 1 year. He does not work out. He has limited range of motion in the right knee. The provider heard S3 heart sounds, which can be a sign of congestive heart failure. His blood pressure was 155/96 while taking hydrochlorothiazide. And he has LVF, EF of 45%, in which norm is about 55%. He has elevated GGT, which means that he needs to think about his liver because it seems that he's drinking too much. He is also African American, which is a risk, and he salts everything prior to tasting it. So when we think about treatment, we would like to do some of the modifiable behaviors first. EW can modify his diet. The best way to modify your diet is to decrease sodium intake. This can be used by doing the DASH diet. EW should exercise daily, 100% decrease alcohol consumption, monitor his blood pressure at home, Continue to take the diuretic and decrease stress, and then monitor kidney functions. It's also important to think about the medications that EW take as needed, such as Sudafed. Sudafed can have an adverse reaction which can cause hypertension. So it is important that the provider and EW discuss if he needs to continue to take Sudafed as needed for his chronic sinus infections. Today, the references for this presentation include 100 case studies in pathophysiology and pathophysiology, the biological basis for disease in adults and children. Thank you for listening, and that concludes his presentation.